Question 1. A 68-year-old patient admitted with acute decompensated heart failure, ADHF, and a history of chronic kidney disease, CKD, suddenly develops altered mental status, muscle weakness, and new-onset U waves on the electrocardiogram. The most immediate nursing intervention should be to A. Administer a rapid 4-potassium bolus. B. Prepare for emergent hemodialysis. C. Initiate continuous cardiac monitoring and obtain a stat serum potassium level. D. Administer a loop diuretic. Answer: C. Initiate continuous cardiac monitoring and obtain a stat serum potassium level. This question tests the recognition and immediate management of severe hypokalemia, which is strongly suggested by the patient's symptoms of altered mental status, muscle weakness, and characteristic U waves on the ECG. The keyword immediate points to the most urgent action. While potassium replacement is likely needed, a rapid bolus without a confirmed serum level can be dangerous, especially in a patient with CKD who may not excrete potassium efficiently. Continuous cardiac monitoring is crucial due to the risk of life-threatening arrhythmias with severe hypokalemia, and obtaining a stat serum potassium confirms the diagnosis and guides treatment. Remember, always confirm electrolyte imbalances with lab work before administering potentially dangerous replacement therapies, and monitor the heart closely for any changes. Question 2. A patient with severe acute pancreatitis presents with a blood pressure of 88/46 mmHg, heart rate 124 bpm, respiratory rate 28 bpm, and oxygen saturation 92% on room air. Abdominal distension is noted, and the patient reports severe epigastric pain radiating to the back. Which intervention should the nurse prioritize? A. Administer 4-morphine for pain relief. B. Initiate aggressive intravenous fluid resuscitation. C. Insert a nasogastric tube to decompress the stomach. D. Prepare for immediate surgical consultation. Answer: B. Initiate aggressive intravenous fluid resuscitation. This question focuses on the immediate management of a patient in hypovolemic shock due to severe acute pancreatitis, indicated by hypotension, BP 88/46 mmHg, tachycardia, HR 124 bpm, and tachypnea, RR 28 bpm. The priority in this critical situation is to restore circulating volume and tissue perfusion. Aggressive intravenous fluid resuscitation is essential to combat the massive fluid shifts into the retroperitoneal space and third spacing common in severe pancreatitis, which can quickly lead to shock and organ dysfunction. While pain relief, gastric decompression, and surgical consultation are important, stabilizing hemodynamics takes precedence to prevent further deterioration. Always address the most life-threatening issue first, which in this case is hypovolemia. Question 3. A 45-year-old patient is admitted with a suspected subarachnoid hemorrhage, SAH. The nurse notes a sudden increase in the patient's systolic blood pressure from 140 mm of mercury to 180 mm of mercury, accompanied by a decrease in heart rate from 90 bpm to 55 bpm, and an irregular respiratory pattern. The nurse should immediately prepare to A. Administer a stat dose of an antiarrhythmic medication. B. Initiate a rapid infusion of mannitol. C. Insert a Foley catheter to monitor urine output. D. Increase the rate of intravenous fluids. Answer: B. Initiate a rapid infusion of mannitol. This question describes the classic Cushing's triad: hypertension, bradycardia, irregular respirations, which is a late and ominous sign of significantly increased intracranial pressure, ICP, a critical complication of subarachnoid hemorrhage. The keywords sudden increase, decrease in heart rate, and irregular respiratory pattern are vital clues pointing to this emergent neurological deterioration. Mannitol is an osmotic diuretic that rapidly reduces ICP by drawing fluid from brain tissue into the vascular space, making its administration a priority to prevent further brain injury and herniation. While other actions may be necessary, addressing the elevated ICP immediately is paramount. Remember that Cushing's triad demands urgent intervention to lower ICP. Question 4. A patient receiving mechanical ventilation for ARDS has an arterial blood gas, ABG, showing pH 7.28, PaCO 258 mm of mercury, PaO 270 mm of mercury, HCO 324 milliequivalent/L. The current ventilator settings are SIMV 14, VT 400 ml, PEEP 10 cmH2O, FiO 270%. Which ventilator adjustment is most appropriate? A. Increase the positive end expiratory pressure, PEEP, to 12 cmH2O. B. Decrease the fraction of inspired oxygen, FiO2, to 60%. C. Increase the set respiratory rate. D. Increase the tidal volume to 500 milliliters. Answer, C. Increase the set respiratory rate. This question tests the interpretation of ABGs and appropriate ventilator adjustments, specifically for respiratory acidosis, pH 7.28, PaCO 258 mm of mercury, in a patient with ARDS. The keyword most appropriate guides the choice. The low pH and high PaCO2 indicate inadequate ventilation, meaning the patient is not effectively blowing off CO2. To correct respiratory acidosis, the primary goal is to increase minute ventilation, which can be achieved by increasing the respiratory rate. While increasing tidal volume also increases minute ventilation, it carries a higher risk of barotrauma and volatrauma in ARDS patients, making an increase in respiratory rate a safer initial approach. Remember that when PaCO2 is high, the ventilatory rate is usually the first adjustment to consider. Question 5. A 72-year-old patient with a history of hypertension and diabetes presents to the emergency department with new-onset atrial fibrillation with rapid ventricular response, AFib with RVR, blood pressure 86/50 mm of mercury, heart rate 148 bpm, and reports dizziness and chest discomfort. The nurse should anticipate preparing for which intervention? A. Administer 4-metoprolol. B. Administer 4-diltiazem. C. Prepare for synchronized cardioversion. D. Administer a bolus of normal saline. Answer, C. Prepare for synchronized cardioversion. This question describes a patient with new-onset atrial fibrillation with rapid ventricular response, AFib with RVR, who is hemodynamically unstable, evidenced by hypotension, BP 86/50 mmHg, rapid heart rate, 148 bpm, and symptoms of hypoperfusion, dizziness, chest discomfort. The keywords new onset, rapid ventricular response, and critically, blood pressure 86/50 mmHg indicate instability. In unstable AFib with RVR, synchronized cardioversion is the definitive treatment to restore sinus rhythm and improve cardiac output, taking precedence over rate control medications which could worsen hypotension. While 4 fluids might be considered for volume, the primary issue is the dysrhythmia affecting perfusion. Remember, instability with a tachyarrhythmia means electricity, cardioversion, is usually the answer. Question 6. A patient is admitted with a suspected severe gastrointestinal bleed. The nurse notes melena, hematemesis, and a hemoglobin of 6.2 g/dl. The patient's blood pressure is 92/58 mm of mercury, heart rate 118 bpm, and they are pale and diaphoretic. The physician orders a stat type and cross-match and transfusion of 2 units of packed red blood cells, PRBCs. What is the most critical nursing action before initiating the transfusion? A. Insert a large-bore peripheral 4 catheter. B. Administer proton pump inhibitor as prescribed. C. Obtain the patient's written informed consent for transfusion. D. Notify the blood bank to pick up the ordered PRBCs. Answer: C. Obtain the patient's written informed consent for transfusion. This question focuses on the essential steps for safe blood product administration, particularly in an emergency, highlighting the legal and ethical requirement of informed consent. The keywords most critical nursing action before initiating the transfusion direct attention to the prerequisite steps. While inserting a large bore 4 and notifying the blood bank are crucial for timely delivery and administration, obtaining informed consent ensures the patient understands the risks and benefits and agrees to the procedure, which is a fundamental patient right unless the patient is unconscious and no surrogate is available in an immediate life-threatening situation, and even then, implied consent applies. But explicit consent is always preferred if possible. Always ensure informed consent is obtained, or appropriately addressed via implied consent protocols in extreme emergencies, before administering blood products. Question 7. A patient with acute kidney injury, AKI, requiring continuous renal replacement therapy, CRRT, via a femoral access line suddenly develops hypotension and a noticeable decrease in blood flow through the CRRT circuit. The nurse observes no obvious external bleeding. The most appropriate initial nursing action is to A. Increase the blood pump speed. B. Administer a rapid fluid bolus. C. Reposition the patient and the extremity. D. Notify the nephrologist immediately. Answer: C. Reposition the patient and the extremity. This question addresses a common complication with CRRT via a femoral access line, specifically related to catheter position and blood flow. The keywords hypotension and a noticeable decrease in blood flow point to a potential issue with the access line itself rather than solely a systemic problem. Repositioning the patient and the extremity is often the first, simplest, and most effective intervention to improve blood flow through a femoral catheter, as changes in body position can kink the line or change the catheter tip's relation to the vessel wall, impacting flow. While other interventions might become necessary, this non-invasive approach should be attempted first. Always assess for mechanical issues with access lines before assuming a systemic problem. Question 8. A patient is admitted to the progressive care unit with a severe exacerbation of myasthenia gravis, presenting with dysphagia, ptosis, and generalized muscle weakness. The physician orders a Tensilon test to differentiate between a myasthenic crisis and a cholinergic crisis. The nurse should ensure immediate availability of which medication at the bedside? A. Atropine sulfate. B. Neostigmine. C. Epinephrine. D. Prednisone. Answer: A. Atropine sulfate. This question focuses on the safety precautions required during a Tensilon, edrophonium, test, which is used to diagnose myasthenia gravis or differentiate crisis types. The keyword Tensilon test is the key clue. Edrophonium is a short-acting anticholinesterase medication that temporarily increases acetylcholine at the neuromuscular junction. While it improves muscle strength in myasthenic crisis, an overdose can precipitate or worsen a cholinergic crisis, characterized by excessive muscarinic effects like bradycardia, salivation, and bronchospasm. Atropine sulfate is the specific antidote for these cholinergic side effects, and its immediate availability is crucial to reverse them promptly if they occur. Always have the antidote readily available when administering medications that can cause severe adverse effects. Question 9. A patient with a history of chronic obstructive pulmonary disease, COD, is admitted with acute respiratory distress. Arterial blood gases show pH 7:30, PaCO 270 mm of mercury, PaO 255 mm of mercury, HCO 336 milliequivalent/L. The nurse recognizes this as A. Acute respiratory acidosis. B. Chronic respiratory acidosis with acute on chronic. C. Partially compensated metabolic alkalosis. D. Compensated respiratory alkalosis. Answer B. Chronic respiratory acidosis with acute on chronic. This question requires interpretation of arterial blood gases, ABGs, specifically in the context of a patient with COPD. The key clues are the pH 7:30, acidocy, PaCO 270 mm of mercury, very high, indicating respiratory acidosis, and HCO 336 milliequivalent/L, high, indicating metabolic compensation. The elevated bicarbonate, HCO3, suggests that the body has had time to compensate for chronic CO2 retention, typical in COPD. However, the still acidic pH, 7:30, indicates that the current CO2 elevation is acutely worse than the body can compensate for, representing an acute on chronic respiratory acidosis. This means the patient has both a long-standing high CO2 and a recent, significant increase in CO2, pushing the pH further down. Recognizing this distinction helps guide appropriate ventilation strategies. Question 10. A patient experiencing delirium tremens, DTs, is agitated, diaphoretic, and experiencing visual hallucinations. The nurse observes a new-onset generalized tonic-clonic seizure. The most immediate nursing action is to A. Administer intravenous lorazepam as prescribed. B. Initiate seizure precautions and protect the patient from injury. C. Obtain vital signs and prepare for intubation. D. Call the physician for further orders. Answer B. Initiate seizure precautions and protect the patient from injury. This question focuses on the immediate, safety-oriented nursing response to an active seizure, specifically in a patient experiencing delirium tremens, DTs, which increases seizure risk. The keyword immediate points to the most urgent action. While administering lorazepam is critical for managing DTs and preventing further seizures, the absolute first priority during an active seizure is to ensure patient safety by protecting them from injury, e.g., padding side rails, moving objects away, and maintaining an open airway. After ensuring safety, medication administration is the next crucial step. Remember, during an active seizure, patient safety is the paramount immediate concern. Question 11. A 55-year-old male patient is admitted with a STEMI and undergoes successful percutaneous coronary intervention, PCI, with stent placement in the left anterior descending artery. 6 hours post-procedure, the nurse notes absent pedal pulses in the affected leg, pallor, and significant pain. The nurse should immediately A. Administer additional pain medication as ordered. B. Elevate the affected leg to promote venous return. C. Notify the interventional cardiologist. D. Apply a warm compress to the leg. Answer C. Notify the interventional cardiologist. This question describes a critical complication following a percutaneous coronary intervention, PCI, specifically signs of acute arterial occlusion in the cannulated extremity. The keywords absent pedal pulses, pallor, and significant pain are hallmark signs of limb ischemia. This is a surgical emergency, often due to thrombus formation or dissection at the access site, requiring immediate intervention to restore blood flow and prevent limb loss. Notifying the interventional cardiologist immediately is paramount so they can assess the patient and intervene swiftly. Delaying notification for other interventions could result in irreversible tissue damage. Always recognize the signs of acute limb ischemia as a critical emergency. Question 12. A patient with cirrhosis and ascites is receiving spironolactone and furosemide. The nurse assesses the patient and notes a new onset of confusion, hysterexis, and a sweet, musty breath odor. The laboratory results show a serum ammonia level of 120 mol/L. The nurse anticipates an order for A. Oral potassium supplements. B. Intravenous albumin. C. Lactulose. D. Paracentesis. Answer: C. Lactulose. This question presents a patient with cirrhosis exhibiting classic signs and symptoms of hepatic encephalopathy, indicated by new-onset confusion, hysterexis, flapping tremor, and a sweet, musty breath odor, Phaeter hepaticus, along with an elevated serum ammonia level. The keyword anticipates an order for directs to the specific treatment for this condition. Lactulose is a synthetic disaccharide that works by acidifying the colon, trapping ammonia, and promoting its excretion in the stool, thereby lowering serum ammonia levels and improving neurological symptoms. While other treatments may be part of overall cirrhosis management, lactulose directly addresses the cause of hepatic encephalopathy. Remember, lactulose helps the gut excrete ammonia, which is the key to treating hepatic encephalopathy. Question 13. A nurse is caring for a patient on a continuous norepinephrine infusion for septic shock. The patient's mean arterial pressure, MAP, has been stable at 70 mm of mercury for the past hour, and urine output is 40 milliliters per hour. The most recent serum lactate is 1.8 mol/L, down from 4.5 mol/L. The nurse notes blanching and coolness to the skin distal to the peripheral 4 site where norepinephrine is infusing. The nurse should immediately A. Administer 500 milliliters normal saline bolus. B. Decrease the norepinephrine infusion rate by 2 micrograms per minute. C. Discontinue the peripheral 4 and restart the infusion in a central line. D. Apply a warm compress to the affected area. Answer: C. Discontinue the peripheral 4 and restart the infusion in a central line. This question describes a critical complication of vasopressor administration via a peripheral 4, extravasation, indicated by blanching and coolness to the skin distal to the peripheral 4 site. The keywords norepinephrine infusion and the described skin changes are vital clues. Norepinephrine is a potent vasoconstrictor that can cause severe tissue necrosis if it infiltrates subcutaneous tissue. The immediate priority is to stop the infusion at the compromised peripheral site to prevent further tissue damage and restart it in a more secure central venous access device. While warm compresses are used for certain extravasations, the priority for norepinephrine is to secure a central line and then consider antidote injection locally. Remember, vasopressors should ideally run through central lines due to their vesicant properties. If extravasation occurs, immediately stop the infusion and secure a central line. Question 14. A patient with a traumatic brain injury, TBI, is being monitored for increased intracranial pressure, ICP. The nurse notes the following trends. ICP 18 mm of mercury, MAP 85 mm of mercury, CVP 12 mm of mercury. Which intervention is most appropriate to optimize cerebral perfusion pressure, CPP? A. Administer a rapid infusion of 0.9% normal saline. B. Administer an intravenous bolus of furosemide. C. Elevate the head of the bed to 45 degrees. D. Administer a prescribed vasopressor to increase MAP. Answer: D. Administer a prescribed vasopressor to increase MAP. This question tests the understanding of cerebral perfusion pressure, CPP, management in a patient with traumatic brain injury. CPP is calculated as MAP-ICP. In this scenario, CPP equals 85 mm of mercury to 18 mm of mercury equals 67 mm of mercury. While 67 mm of mercury is within an acceptable range for some, the question asks for the most appropriate to optimize CPP, implying a need to improve it further or address a potential trend towards decline. Given the current ICP of 18 mm of mercury, which is borderline high, normal less than 20 mm of mercury, increasing the MAP with a vasopressor would directly increase CPP, thereby enhancing cerebral blood flow without significantly raising ICP further. Administering furosemide, a diuretic, or elevating the head of the bed might decrease ICP but could also reduce MAP, potentially leading to a net decrease in CPP if not carefully managed. Normal saline bolus could increase ICP. Optimizing CPP is crucial for preventing secondary brain injury. Remember, to optimize CPP, you can either decrease ICP or increase MAP. Question 15. A 60-year-old patient is admitted with a suspected pulmonary embolism, PE, presenting with acute dyspnea, pleuritic chest pain, and hypoxemia. The patient is prescribed a continuous unfractionated heparin infusion. Before initiating the infusion, the nurse should confirm that which laboratory result is available and within therapeutic range. A. Prothrombin time, PT. B. International Normalized Ratio, INR. C. Activated partial thromboplastin time, APTT. D. Platelet count. Answer, D. Platelet count. This question focuses on the essential baseline laboratory assessment before initiating unfractionated heparin therapy. The keyword "before initiating" highlights a critical pre-administration check. While APTT is used to monitor the therapeutic effect of unfractionated heparin and PT/INR for warfarin, a baseline platelet count is crucial before starting heparin. Heparin-induced thrombocytopenia, HIT, is a potentially life-threatening complication where heparin causes a significant drop in platelets. Knowing the baseline platelet count allows the nurse to monitor for this complication, making it a critical pre-infusion assessment. Always check the baseline platelet count before starting heparin to monitor for HIT. Question 16. A patient with severe sepsis is receiving broad-spectrum antibiotics and aggressive fluid resuscitation. Despite these interventions, the patient's CVP is 10 mm of mercury, MAP is 60 mm of mercury, and lactate is trending upwards at 3.5 mol/L. The nurse identifies new orders for a dobutamine infusion. The primary goal of administering dobutamine in this situation is to A. Increase systemic vascular resistance, SVR. B. Improve cardiac contractility and cardiac output. C. Decrease myocardial oxygen demand. D. Promote renal vasodilation and diuresis. Answer, B. Improve cardiac contractility and cardiac output. This question tests the understanding of dobutamine's mechanism of action and its indication in septic shock when there is evidence of myocardial dysfunction despite adequate fluid resuscitation. The keywords CVP is 10 mm of mercury, suggesting adequate preload, MAP is 60 mm of mercury, persistent hypotension, and lactate is trending upwards, ongoing hypoperfusion, indicate that the patient needs improved cardiac output. Dobutamine is a positive inotrope, meaning its primary action is to increase myocardial contractility, thereby improving cardiac output and oxygen delivery to tissues. It has minimal effect on SVR at typical doses. Its main goal is to pump the blood more effectively. Remember, dobutamine helps the heart pump stronger, which is crucial when the heart isn't keeping up with the body's demands in shock. Question 17. A patient with diabetes insipidus, DI, is receiving desmopressin. The nurse notes the patient is confused, has a headache, and has gained 2 kilograms overnight. Which laboratory result would the nurse anticipate and be most concerned about? A. Serum sodium 155 milliequivalent/L. B. Serum osmolality 310 mosm/kg. C. Urine specific gravity 1,002. D. Serum sodium 128 milliequivalent/L. Answer D. Serum sodium 128 milliequivalent/L. This question tests the understanding of potential complications of desmopressin therapy for diabetes insipidus, specifically related to fluid and electrolyte balance. The keywords confused, headache, and gain 2 kilograms overnight are classic signs of fluid overload and hyponatremia. Desmopressin is an antidiuretic hormone analog that causes water reabsorption. If given in excess or if the patient continues to drink excessively, it can lead to water intoxication and dilutional hyponatremia, where the serum sodium level drops significantly. A serum sodium of 128 milliequivalent/L confirms severe hyponatremia, which directly explains the patient's neurological symptoms and weight gain. While other options might indicate poor DI control, hyponatremia is the most critical and concerning complication in this scenario. Remember, too much desmopressin can lead to too much water retention and dangerous low sodium levels. Question 18. A patient is intubated and mechanically ventilated. The high-pressure alarm on the ventilator consistently sounds. The nurse has assessed for kinks in the tubing, suctioned the patient, and ensured the patient is not biting the tube. The next most appropriate action is to A. Increase the ventilator's tidal volume. B. Administer a prescribed sedative or neuromuscular blocking agent. C. Briefly disconnect the patient from the ventilator and manually ventilate with a bag valve mask. D. Increase the pressure limit on the ventilator. Answer C. Briefly disconnect the patient from the ventilator and manually ventilate with a bag valve mask. This question addresses troubleshooting persistent high-pressure alarms on a mechanical ventilator. After ruling out common mechanical issues, kinks, secretions, biting, the persistent alarm indicates a significant problem with lung compliance or airway obstruction that could be life-threatening. The keyword "next most appropriate action" guides the immediate response. Briefly disconnecting the patient and manually ventilating with a bag valve mask allows the nurse to assess the patient's lung compliance directly and provides immediate relief from potentially dangerously high airway pressures, identifying if the issue is with the patient or the ventilator circuit. This action provides immediate control and assessment. Remember, if you've checked the obvious and the high-pressure alarm won't stop, disconnect and bag the patient to ensure ventilation and troubleshoot safely. Question 19. A patient is admitted with a hypertensive crisis, presenting with a blood pressure of 220/120 mmHg, headache, and blurred vision. The physician orders a continuous 4 infusion of nicardipine with a target mean arterial pressure, MAP, reduction of no more than 25% in the first hour. The patient's initial MAP is calculated as 153 millimeters of mercury. The nurse should aim for a MAP range of A. 90 to 100 millimeters of mercury. B. 115 to 120 millimeters of mercury. C. 125 to 135 millimeters of mercury. D. 130 to 140 millimeters of mercury. Answer C. 125 to 135 millimeters of mercury. This question requires the nurse to calculate the safe target range for blood pressure reduction in a hypertensive crisis, which is critical to prevent hypoperfusion and organ damage. The keywords no more than 25% in the first hour and initial MAP is calculated as 153 millimeters of mercury are essential for the calculation. To determine the lower limit of the target MAP, calculate 25% of the initial MAP, 153 mmHg asterisk 0, 25 equals 38, 25 mmHg. Subtract this from the initial MAP, 153 mmHg 38, 25 mmHg equals 114, 75 mmHg. Therefore, the MAP should ideally not go below approximately 115 millimeters of mercury in the first hour, but the target range generally aims for a slightly higher, conservative reduction, usually around 125 to 135 millimeters of mercury, to allow for controlled, gradual lowering while maintaining adequate perfusion. The goal is a controlled drop, not normalization, in the first hour to prevent ischemic damage. Remember, slow and steady wins the race when lowering blood pressure in a hypertensive crisis to protect the organs. Question 20. A patient presents with crushing substernal chest pain radiating to the left arm, diaphoresis, and nausea. The ECG shows ST elevation in leads 2, 3, and AVF. The nurse correctly identifies this as an inferior wall myocardial infarction, MI. The nurse should be particularly vigilant for which complication? A. Left ventricular failure. B. Atrial fibrillation. C. Right ventricular involvement leading to hypotension. D. Ventricular tachycardia. Answer, C. Right ventricular involvement leading to hypotension. This question specifically tests the understanding of complications unique to an inferior wall myocardial infarction, MI. The keywords ST elevation in leads 2, 3, and AVF definitively diagnose an inferior MI. The inferior wall of the heart is often supplied by the right coronary artery, RCA, which also supplies the right ventricle. Therefore, an inferior MI frequently involves the right ventricle, RVMI, which can significantly impair its ability to pump blood to the lungs, leading to reduced preload to the left ventricle and profound hypotension, especially with nitrates or diuretics. While other complications can occur, RV involvement and subsequent hypotension are a specific and critical concern with inferior MIs. Always be alert for signs of right ventricular infarction and avoid preload-reducing medications in these patients. Question 21. A patient with diabetic ketoacidosis, DKA, has the following lab results: pH 7, 18, PaCO 2 28 mm of mercury, HCO 3 10 milliequivalent/L, glucose 650 mg per deciliter, potassium 3, 0 milliequivalent/L. The nurse initiates an insulin infusion and aggressive fluid resuscitation. Which electrolyte imbalance is the most critical to monitor and address first? A. Hyperglycemia. B. Hypokalemia. C. Acidosis. D. Hyponatremia. Answer, B. Hypokalemia. This question challenges the understanding of prioritized electrolyte management in diabetic ketoacidosis, DKA. The keyword most critical to monitor and address first is crucial. While hyperglycemia, acidosis, and potential hyponatremia are present and require treatment, the existing hypokalemia, potassium 3, 0 milliequivalent/L, is the most immediate life-threatening concern in this scenario. Insulin therapy, which is essential for DKA, drives potassium into cells, further exacerbating hypokalemia. Severe hypokalemia can lead to fatal cardiac arrhythmias. Therefore, potassium replacement must often be initiated before or concurrently with insulin infusion, provided the patient is not anuric, to prevent critical cardiac complications. Always prioritize potassium replacement in DKA if the level is low or even normal, as insulin will drop it further. Question 22. A patient with severe acute respiratory distress syndrome, ARDS, is on mechanical ventilation with a PEEP of 15 cmH2O. The nurse notes new-onset subcutaneous emphysema around the neck and chest, absent breath sounds on the right, and sudden hypotension. The nurse should immediately prepare for A. Administration of a broad-spectrum antibiotic. B. Initiation of a dobutamine infusion. C. Needle decompression or chest tube insertion. D. Increase in the inspiratory time on the ventilator. Answer: C. Needle decompression or chest tube insertion. This question describes classic signs of a tension pneumothorax, a life-threatening complication, especially in patients with ARDS on high PEEP. The keywords new-onset subcutaneous emphysema, absent breath sounds on the right, sudden hypotension, and ARDS, high PEEP are critical clues. High PEEP can cause barotrauma, leading to alveolar rupture and air leaking into the pleural space, which can progress to a tension pneumothorax. This medical emergency requires immediate decompression to relieve pressure on the heart and lungs, typically via needle decompression followed by chest tube insertion. Other options are not appropriate for this emergent respiratory compromise. Remember, absent breath sounds, subcutaneous emphysema, and hypotension in a ventilated patient on high PEEP signify a tension pneumothorax requiring urgent decompression. Question 23. A patient with a history of intravenous drug use, IVDU, is admitted with infective endocarditis and develops acute onset right-sided weakness, facial droop, and expressive aphasia. The nurse's immediate priority is to A. Prepare the patient for emergent cardiac surgery. B. Administer 4 antibiotics as ordered. C. Perform a rapid neurological assessment and notify the stroke team. D. Initiate continuous cardiac monitoring. Answer: C. Perform a rapid neurological assessment and notify the stroke team. This question describes a patient with infective endocarditis who is experiencing an acute ischemic stroke, a common and severe complication due to septic emboli. The keywords acute onset right-sided weakness, facial droop, and expressive aphasia are classic signs of a left cerebral hemisphere stroke. The immediate priority is to recognize these signs and activate the stroke team for rapid evaluation and potential thrombolytic therapy or thrombectomy, as time is brain. While antibiotics for endocarditis and cardiac monitoring are ongoing, addressing the acute neurological deficit is time-sensitive and critical to minimizing permanent disability. Always prioritize emergent neurological assessment and stroke activation when a patient exhibits acute stroke symptoms, regardless of their underlying condition. Question 24. A nurse is reviewing the arterial line waveform for a patient in septic shock receiving continuous vasopressor infusions. The nurse observes a dicrotic notch that is not clearly visible and a widened pulse pressure. Which interpretation of the waveform is most accurate? A. The patient's systemic vascular resistance, SVR, is likely high. B. The patient is responding well to vasopressor therapy. C. The patient's SVR is likely low. D. The arterial line transducer needs to be re-zeroed. Answer: C. The patient's SVR is likely low. This question tests the interpretation of arterial line waveforms in the context of septic shock. The key clues are dicrotic notch that is not clearly visible and widened pulse pressure in a patient receiving vasopressors for septic shock. A dicrotic notch, which represents aortic valve closure, becomes less pronounced or absent when systemic vascular resistance, SVR, is low, indicating a rapid runoff of blood. A widened pulse pressure, difference between systolic and diastole, also suggests low SVR and often high cardiac output, as the heart ejects blood into a less resistant vascular bed. These findings are characteristic of distributive shock, like septic shock, despite vasopressor support. Remember, a flat or absent dicrotic notch and wide pulse pressure often point to persistently low SVR in shock states. Question 25. A patient with a Glasgow Coma Scale, GCS, of 7 is receiving continuous enteral nutrition via nasogastric tube. During routine assessment, the nurse notes gastric residual volume, GRV, of 450 milliliters. The most appropriate initial nursing action is to A. Discontinue the feeding and notify the physician. B. Hold the feeding for 1 hour and recheck GRV. C. Administer a prokinetic agent as prescribed. D. Return the GRV to the patient and continue the feeding at a slower rate. Answer: A. Discontinue the feeding and notify the physician. This question addresses the management of high gastric residual volumes, GRVs, in a patient receiving enteral nutrition, particularly in a neurologically compromised patient, GCS7, at high risk for aspiration. The keyword most appropriate initial nursing action and the GRV of 450 milliliters are critical. While GRV thresholds vary by institutional policy, a volume of 450 milliliters is generally considered high and puts the patient at significant risk for aspiration. The priority is to stop the feeding immediately to reduce this risk and then notify the physician for further orders, which may include delaying feeding, administering prokinetics, or assessing for other causes of delayed gastric emptying. It is unsafe to continue feeding with such a high residual. Always prioritize patient safety, and high GRVs warrant holding the feeding and notifying the provider to prevent aspiration.